So AAA. This is one that's going to load over everything, so I got to click on this until they all pop up. There we go. So what we're going to do, we're going to talk about identifying them. I think I kind of talked to you a little bit about this before of how things represent, what causes them. There's different type of aneurysms that present. What's the big deal about them? How are they going to look? What are you going to see from there? I'll show you some other pictures. We'll talk about the sever, talk about the swell, surgical repair. We kind of went over a little bit of things and how they're going to present, signs, symptoms, and treatment. So what is an aneurysm? Basically, it can be a couple of different things that pop up. The typical way we talked about in that pulsating mass is that there's actually on the, and typically we talk about AAA, so we're talking about the abdominal portion of the aorta. There's a hole, there's a leak, there's a stretch, there's a tear, there's some aspect that fluid's being pushed into another sac, and it's basically creating an out pocket. Well, why does this happen? Well, a couple different things that happen, and these can happen in other areas too. If you get pressure on those areas over a period of time, and we're talking about people who become hypertensive, right? So they're getting 190 systolic pressures and things like that. Pressures on those vessels can only take that pressure for so long, so you get weakening at different spots. Well, you get a weakening of this spot, and all of a sudden on one of those pulses, it stretches and bubbles out. Now some fluid went into that area. Now maybe a little bit more fluid, and it'll actually cause more stretching in this area. And you'll cause basically an out-pocketing or an out-pouching coming up, and a little stock that'll come over there. Gets rid of the elasticity, if you will, of that area, and it just keeps stretching that area, and it'll fill up. If it gets enough pressure diverted in there, it'll get larger. It can stay something small. It can grow over a period of time. As it forms, it can actually form its own little artery, if you will, and muscle side inside that, and basically just be a direct out pocket. Those are the cases where it's truly going with a pulse and filling up. That's what we call a pulsatile mass. So when you push in, you feel that mass, and it has a pulse sensation. It means it's a direct feed from the aorta, from the artery. It's going right into there, and it'll fill. Other type of aneurysms, you can have a dissecting aneurysm. Basically on there is you get an area that's basically splitting open, and blood's filling out of that. And that's going into between a space in the area. So what do we know our layers of the blood vessel? Everyone did very well on that. So you guys did the heart layers, actually, didn't you? Epicardium, myocardium. So endo, epi, myo. So we also have layers on the artery cells too, on the artery vessel walls. So those have different layers. So we'll actually get a tearing of the inner cell, and that fluid will go in through, and it'll expand around the aorta itself. Those can dissect completely and rupture if there's enough of a tear through it, and go through all three layers of the wall as well. But the aorta has a very muscular wall, so it's usually that inner layer tear, and it'll go out and it'll be fused in that inner layer of the artery itself. And that can go through. The problem with that is once it breaks through that inner layer, how does the artery interior muscle work? Well, it's actually continuous, right? So if we look at the artery itself through a cross section, and we have our layers here. They come around this, and this being each of the layers right there. So if we get a breaking in this area right in here, and that blood starts to fill this area, well, it doesn't just fill it in this spot. If I look at the aorta like this, it can now, if this is where the tear is, it can tear into this portion here, but now that can fill this whole stream, right? It can actually space throughout this. This isn't, the artery wall isn't ballast. It isn't walled off. So once it gets that area, it can dump. So you can lose a ton of fluid within inside that muscle wall, and so it opened. That's why these dissecting are so important, and you can lose a lot of fluid quickly into that area, and it'll keep bleeding. As opposed to this, where you get this little out pocketing, basically like this, and this is filling up. How fast can that fill? Well, it can only fill to the speed that this stretches, and this stretches over a short period of time. It grows a little bit every day. The lady I talked to you about who had the full-size, football size, that probably took several years. I mean, we're talking multiple years for that area to grow and to be compressing. It doesn't stretch. Whereas this, breaking into this area, that takes seconds. Now it just starts filling that up entire aorta. So you can lose a lot of fluid a lot faster. That's why dissecting aneurysms are so dangerous, and people can die instantaneously to over several minutes. And it's that tearing or that shearing force too. And you think about that abdominal, it's basically set into a cavity, and if you have velocity or speeds that move the body, that area, that muscle, I can't think of the name of it, but the tissue holding those vessels in place, getting the aorta in place, can get torn and moved, and so that area can fail. And so as that tears or stretches, blood can drop right in there, and you can lose most of your volume very quickly. It can fill up, yep, and it can do that too, because there's nothing once you get into that inner side layer. And if that tore across, so let's say, again, now I'm dealing up towards the arch area, but when I'm dealing with the arch of the heart here, and that heart moves and this tears up in here, that can tear not just the layer, but that can tear the whole thing apart. Now it's just jumping, it's a faucet right into the cavity. So, and that's where we talk about, when I talked about MVAs, where you get not only the collision of the car, the body into the car there, but now the aorta or the heart moving forward. The aorta is being strapped down, but as the heart moves forward, that causes that tearing or that shearing. Same thing can happen with the liver, the ligament tears. That movement across there causes a tearing. There's nothing to stop it. Now the blood just goes into whatever cavity it was in. So you can lose a lot of volume very quickly with those. So that's why these are important to identify as quickly as possible. And mostly the only way you can do these is by asking the question to the person. What happened? What did it feel like? Trying to find those symptoms of going.
And so with a non-dissecting aneurysm, all three of those layers are completely intact.
Absolutely.
Stretched.
Yep. They're intact, but it's basically out-pocketed.
Gotcha.
So this basically just kind of pushed out. So on the spot where we look at that cross-section, it may look like this. And then back into this layer, and then this layer looks like this, and so on and so forth. So as we're looking at it, there's just this little column or little stock. And I'll probably get to this as I get further into that. But the thing that I would see a ton of what's called ganglion cysts. It's the same thing around a tendon sheath will pop up, and you get these little fluid-filled sacs. It's basically synovial fluid. It's the same thing as an aneurysm is, except it's synovial fluid around a sheath instead of an artery. I never dealt with this. I'm not a vascular surgeon, nor would I ever want to do this. But I dealt with something very similar, so I know treatment-wise, so we're going to talk about that as well, too. Yeah?
The one thing I talked to my wife about is that you ever take a balloon and try to pop it, and you get one section that stretches, and you hold it there, that's kind of fits in.
Yeah. Yep. So, and it just basically just fills out there, and it starts off small, but it just keeps stretching. Good analogy. So, yeah, it'll pop out there, and it'll just fill up across.
So the second aneurysm can either be when your bulge ruptures, or it can be just a tear inside your inner layer.
It could, or it can be a tear of the whole vessel. So the dissecting basically separates that wall. So the wall in this case is actually still intact, right? There's still a stock. Dissecting means a tear. Now it could be a tear like this between the wall, or it could be a tear like this. We don't know. It can vary on different things. So dissecting aortic aneurysms are the ones that are going to kill you. The basically pulsatile mass usually are not going to kill you. Those are the patients, if you're going to find a AAA, those are the kind you want to find. I'm going to get through a couple other things in here, slide-wise. They say men are more likely than women. This is the one case where out of all these numbers, I'm usually the anomaly to these. Usually, like they'll tell you it was, you know, young women in their 20s for angina, for prismal angina. I usually see it in men. This is the one, the only three that I've seen have all been men, and they've all been in their 40s, 50s for presentation-wise. So what are the extent or causes, risk factors are going to be atherosclerosis. Hypertension is going to be the biggest one because we're actually causing, as far as the standard AAAs, where we get the bulging out pocketing. Hypertension is going to be at blunt trauma is going to be something that can cause an injury or cause a weakening of the vessel. It can cause either one of those. Diabetes and basically any type of things that can add injury with too high of sugar levels and things like that can irritate the wall. Marfan syndrome is basically a connective tissue disorder where you get a lot of stretching in that. You actually lose some elasticity in other areas, and so you can get that area where it's connective tissue. As far as the incidents, again, I'm going to have to agree with this one, and it's majority of all the instances I've seen is mostly 40 to 70 years old, and it's been mostly in men in those categories. So why is this important to you? Well, basically because they can lose a ton of fluid over time, and this is basically going to be your main blood supply. This is your arterial blood. This can kill people over a quickly area. Some aneurysms can be slow. They can grow with size, and those are actually surgically easy to fix. Others are basically going to be very quick, and you've got a short span to work with this patient, and they're in a serious condition of what you're going to do. So you've got to determine those things, and basically it's pretty much by history as far as the dissecting ones. Even on them, you're some of a guess. I talked to you about, this is referring more to AAA, but the two females I know who survived the dissecting, neither one of them complained of chest pain. They were complaining of, my cousin was nausea and felt like she had almost wanted to throw up and having a reflux, was a presentation. When they took her in and were going in to check her out, that's when they found it. And apparently on the table, she even heard the doctor go, "Oh shit." So she's like, "What? Never mind, you're going to sleep," and went out. Basically, she was dissecting on her as they went in with the scope to see. They stretched it, and it actually, the section just kept spreading along the case. So wasn't there for that. But so they are going to be something that's very serious in those aspects. Those are the ones that you don't want to see. And the dissecting aneurysms are not going to have the pulsatile mass. What do they present like? Well, here's a CT scan showing your mass right there. So they can present as an abnormal mass when you're going out to the area. What level are we right here? What vertebra is this? So when we're noting, basically, if you look at the position of here and your spinous process and your area, this is actually a thoracic vertebra. You're going to see basically your lumbar vertebra is going to be a little bit different, but you're probably sitting on this one at right about T11, T12, based on the position of the spinous process and how you look at the back on that. So when we're looking at, you're going to see this mass, and so searching through this as you float into it, you'll see the different sizes on there, and then you'll see right where the aorta sits. So basically, this one is gotten large enough to where it's coming close to the anterior wall, right? The ventral surface, right here, building up. But a lot of times, these are going to be building up back into this spot. The aorta sits right in that spot, right? Right over top. Here's another look at that in 3D kind of picture. So what this one happened to do is the aorta sits right in here. It's right inside this spot. And that's going to be the main flow if you're looking in that top picture right there. And this built all right around it, filled up into this wall, and built all around that aspect. Here's goes down to each of the femoral arteries. And that aorta is sitting about right there. As that mass gets big, it'll actually push that aorta to the side. The mass will push off. So if we go back in here, this should be where the aorta should be sitting, and you can see it's actually pushed off now towards the right side of the body.
So our aorta splits off the femoral arteries around T12 then?
No. This is a 3D creation. This is a different spot. See right here? This is still the mass. No, you'll split off down here in the lumbar area, I think is where it takes off. And I don't know if it's L2 or L3, it'll actually split it to the area down below where that bifurcation occurs. But this is a cross section. This is looking at a different plane. So we're looking at the up and down, not the cross section. If we're looking at that cross section may have been like right through here, across that area or something where we're seeing. And this is another way this can present. This can present where it basically builds up right around the side. The one that I particularly saw that we dissected, it actually had its own stalk, and it was built up off the side to the area. So the aorta was still intact. We could dissect the aorta, but it was its own stalk that it built up, and it was built around the side. So how are these discovered? Most of these are going to be for those different reasons. Patient coming in for an ultrasound for some other reason, stomach pain, other aspects that come in. It usually does not come in for normal presentation of areas, but it's normally discovered other aspects of people getting checked out. This lady that we saw died for an unknown reason. I can't remember what the reason was, but she probably never even knew she had a AAA in her. They can develop over there in period of times. As opposed to those patients who have a dissecting aneurysm, those are usually going to be associated with something. Again, with my cousin and this other female, it did not occur that way, but the three that I did normally presented in different aspects. And the main aspect that I'm going to tell you is going to be a presenting sign. And this is why pretty soon, like we said, we're going to start sharing more and more when you guys go on calls, because you learn a ton from what you hear from other people. So that's why I want to share my experience with you. So if you see it, maybe you'll remember this. But basically, the three people that we had, all males, all presented with the same thing, sharp back pain. And they all described it as, it felt like someone hit me in the back with a baseball bat, with a broom, with a stick. So they feel that, they drop to the ground, and they lost all function in their legs. I can't stand up. I can push myself up. They can't stand up, and they have no pulses down in their leg. All presented in that way. So I want you to go, if that comes in, just immediately put into your head that they've got potentially a dissecting AAA. Again, going to your point, like you're saying, over-treat it, then under-treat it, but those causes from there. And the first one I got, I was on my preceptor ride time at Life Fleet Ambulance, and was shitting my pants when my preceptor goes, he passed me, we used to say rule out was our term. So when we did diagnosis, it was RAAAA, and he passed me the sheet, and I'm like, oh shit. That's not how I was taught AAA in my paramedic school. I was taught a AAA was a pulsatile mass. That's how I was taught in my medical school. He goes, nope. He goes, this is it. Let's go. So we scooped, we ran, and we were starting to dump fluids on him, and we stopped fluids immediately on him running for there, because what are we going to do if we start adding more fluids? We're going to open it up. We're going to cause more tearing and dissection on there. That gentleman did make it to the hospital. He did make it to surgery. One of the other ones did not. Made it to the hospital, died before he could go up there, bled out from there. So you have minimal time on those things. So the quicker you can kind of diagnose what that is, the quicker you're going to have the ability to find those. But always be wary, especially middle-aged men. Sharp pain, felt like someone hit me in the back, I can't stand. Until further, use that as a rule up. As far as the other aspects, most of these can be surgical repaired. And if repaired like that, what they're going to do is they're going to go inside and they're going to find the artery wall, and they're going to go in and surgically fix everything. The area is dissected. They'll pop in, especially if it's the abdominal area, it's a thick muscle, they'll probably open up the area. They'll actually clamp off. They may actually hook up to, it's not quite like the ECMO, but they'll do a circulation system across there to keep the blood flowing towards the body. But they'll clamp either sides off. They'll open it up and they'll surgically kind of repair the whole thing. Sometimes they'll do a graft on there. Depends on where the aorta is and how big area. When we're dealing with arch areas or smaller vessels, what they'll actually do is, I showed you the, let's see if I've got one on here. They'll actually do something like this, where they'll either bring a graft and put it in place and suture it around, or two, they're trying to do everything through the femoral artery now. So they'll pop that graft in, take it right up to the spot, balloon open up, slide this new implant in over the spot, and they'll suture that in and get in place in the wall from where the tear was. So they can fix it that way as well. There's a couple different routes. Now, when they're dealing with something like this, or where the area is coming into here, they'll actually they similar do the same thing. They'll actually find a position above the area. If this one right here was a stock where it's coming off the side, they'll actually just clamp this area off, cut this area, and dissect and remove that, and then they'll come in and they'll cauterize this area, close it off. It's actually pretty simple. When it's actually like those pictures I showed you before where it's actually around the area in the wall, there they have to clamp that artery off on both sides of the aorta, remove that whole section, and usually get in a graft in there because it's so built up of scarring tissue around there. Different ways to approach it. But for those when they're dissecting, the biggest thing they're going to do is on here is you want to get pressures maintained to about 70. You want to maintain there. So if their pressures are below 70, you'll run fluid just to 70. You don't want to be any more than that because you still got to get blood flow around to that spot. And then get them up and be worn in the hospital to get them up for OR as quickly as possible. Let's see.
Dr. Pride, how are you?
Glenn Pride spent years taking care of people as a physician. Now he is the patient, under the care of vascular surgeon Dr. Frank Arco.
It was an ultrasound that found the aneurysm. How are you doing since you had your procedure?
Dr. Arco repaired Dr. Pride's abdominal aortic aneurysm.
That woke me up a bit because it was oftentimes capable of rupturing, and you have very little time to at least get to an office or get to wherever to be cared for.
Take a big deep breath in.
Abdominal aortic aneurysms grow slowly and have few symptoms to warn of their presence. When they rupture, aneurysms cause severe internal bleeding, and patients need immediate medical attention.
There have certainly been many famous people who died of ruptured aneurysms, including Albert Einstein, Lucille Ball. So it can be very common, and it can happen to anyone.
An abdominal aortic aneurysm is in the aorta, the body's largest artery which carries blood from the heart. Sometimes the pressure of pumping blood causes a weak part of the aorta to bulge. Patients can experience a pulsing sensation in the abdomen, severe unexplained pain in the lower back, or on rare occasions, pain or discoloration in the feet when material from the aneurysm sheds and moves.
Most often, it's smaller pieces that travel down to the foot and result in a blue toe syndrome. So anyone who presents with sort of discoloration of the toes in a workup should be looked at to make sure that they don't have an aneurysm. Dr. Brown, we're going to feel that aneurysm.
At times, doctors can feel an aneurysm around the belly button during an exam, but most are found, like Dr. Pride's, during tests for other conditions.
The most common way that we have patients refer to us is that they're in the workup of another issue. They undergo a CT scan or an ultrasound, and during that imaging study, they're found to have an aneurysm that's quite large, and then that needs to be repaired.
Most aneurysms are found in patients over 60, and doctors recommend screening at age 65. Men are more likely to develop them than women. Factors that contribute to risk for aneurysms include smoking, high blood pressure, high cholesterol, obesity, atherosclerosis, also referred to as clogged arteries, and family history of aneurysms. Most important, patients with diagnosed aneurysms need to be under the care of a vascular surgeon.
You had to do some convincing that I need to be done now, not 2 or 3 months later. I was pleasantly surprised when it all turned out well.
Ask your doctor about your risks for vascular disease. Visit vascularweb.org to find a vascular specialist and learn more about vascular wellness.
So some of the signs and symptoms basically can present a lot of different ways. As they talked about though, usually the way that we're seeing on here for AAAs is that low back pain. Be looking for that aspect. Again, be aware of each of those because still, as far as National Registry and most educational areas I've seen testing wise, they still refer to looking for this, for the pulsatile mass. So there is a pulsatile mass right there. But that is not a common area that you're going to find or way for that being diagnosed.
Would you want to avoid palpating that?
Because you're worried about pressure and up. No, if it's pulsating like that, you definitely want to.
Oh, really?
Yeah. It depends on how much pressure you want to put on it. But again, if you're dealing with most masses, I mean, if it's right up in there, it's got to be fairly large and it's pushing through. Most ones you actually have to push down into the abdomen to find. But if I had that, heck yeah, I'd be waiting to figure out what's in there, wait for the alien to jump out and get me.
So, a week or so ago, I actually had, I don't think it was this, the doctor transported over to the higher facility and actually said it was an anterior descending gas, or not gas, it was intestinal artery. But it kind of presented that same exact way. It wasn't pulsating. I didn't spend time, playing around with it.
Yeah.
But you could feel it. I mean, it was like, it was rigid. It was a totally different part of the abdomen. And she was just outside doing whatever, nothing strenuous. And someone started and came inside, and she was in excruciating pain. I just thought she was going to wuss, to be honest with you. Until I found out what it was, and I felt bad.
Yeah. Well, you got to think about this. We're talking about AAA, right? But this can happen with any artery, right? So it doesn't have to be the abdominal aorta. So
Well, and
that
I
was
wish
a,
there were no more to actually probably would have felt it a little bit more to see if I could feel it pulsating.
yeah, this can actually happen to any artery, and it can be small. You could probably get one, on an artery in your wrist. If you had enough pressure in the spot and it comes up, you can develop them there. I mean, there's no reason it couldn't happen at any type of artery vessel. Obviously, you're dealing with different size. The biggest one, obviously, if I get a break in my artery here, I'm probably less concerned than my abdominal one, obviously. But you can get aneurysms developing from lots of different things, right? So that would have been definitely an interesting one to see. And that being up on the gastric area, it's going to sit more prominent to where you would feel it.
Yeah, it was over on her right side. And she had she called it anything that was like diverticulitis again. She had that before.
Yeah.
And when I felt that, I'm like,
Yeah. So these can present all different ways. Here's just a couple different aspects depending on where it is, especially if we're dealing with a higher one. They can present areas here. But again, biggest thing, especially when we're dealing with our main ones, is listening to that tearing sensation, that pain, especially low back if we're referring to abdominal. Thoracic ones can all change different ways. These are pretty common of what you're going to see. So why are we going to see tachycardia with these aneurysms? Right. Exactly. So we're going to be pumping there. So you're going to become diaphoretic from these areas, from building up from that pressure coming off. You can feel nausea and vomiting basically being referred there. And obviously, faster the heart goes, you're going to have more problems with breathing. It's all going to be related on there. So other type of things that we can see with this, syncope related, most of these people are going to present in other ways. And that's kind of what they said in that video we're talking about. Most people are actually referred. They're not coming in diagnosed with an aneurysm. They're found from different aspects. This would be the most words and areas that I'd be looking at for those areas is that ripping or tearing sensation. Felt like something's tearing inside. Listen to those things and basically put that heightened awareness on you. And especially dealing with these three things right in here of coming up. I've experienced, like I said, 3 times. It can be really common to see. So be aware of those. Be aware of asking the questions. What did it feel like? How did it come on? Anything like that.
What was it saying about 2/3 of the cases, the ascending?
2/3 of the cases of dissection, the ascending aorta is involved.
So that's the one going
Up, out of the heart. So, and that's both where my cousin and this other lady had. So, yeah. I am not familiar with the ECG findings with AAA. So, again, they're saying right coronary is obviously associated with the inferior MI. Makes sense, right? If we look back on that graph in 12 lead of which area is going to be going from there. But as far as the findings on this area, I was unaware of this, so I'm going to look more into that area, and I'll come back and talk to you about those. This is more talking about aortic arch aneurysms and AAAs on there, but I always like to find out different things on 12 leads for finding. We're going to teach you how to see a lot of things on 12 leads, so I'll look more into that aspect because that part I didn't know. So what are we going to do treatment-wise?
I'd go 2.4 IVs, diesel bolus.
What else? So that's where the change is going to be in, and I want you guys to know 90 for National Registry. And it's the same as what's the pressure we want to get people at after trauma? 90, that's what we talked to. What's that? No, go ahead. What'd you say? Yep. So, and actually the changes are going to be coming into, because we're going to go towards MAP, but if you have talked to most trauma surgeons, and the big thing is we're going to get a lot of changes, I think, over the next couple of years because people are talking more and more. What I mean by that is a lot of the docs in town don't know what our protocols are, right? Trauma surgeons have no idea what we do in some cases. They're starting to learn more and getting more interaction between these things. So trauma surgeons are now coming and presenting at a lot of our EMS conferences, things like that. And they're basically saying too, we want to see pressures at 70. You guys are causing too much damage by having pressures at 90. Put it 70. 70 gets perfusion, it causes less damage to the areas they have to work. So there's going to see some changes. For right now, I want you guys to know 90 on everything because that's what National Registry and testing. What's the minimal systolic you want to get to? AJ is going to talk about that. From return to spontaneous circulation, you're going to want 90. Okay, so certain things there. So I want you to know those numbers, but real life, I want you to know that we're going to aim towards 70, and especially with a dissecting aortic aneurysm, you do not want to be pumping 90 because you're going to get that tear going further and further. You're going to cause more trauma. So 70 is just fine. Obviously, we're looking for a rapid transport, short scene time. Pain management is going to be the way, depending on how much pain they're going to be in. What do you think about this? Are you? Yep. So nitro, what's that gonna do? Gonna vasodilate. Yep.
We don't know what kind of serious aneurysm they have.
No.
I mean, I guess it has a form that takes some tension off of it.
Yeah.
It's
So-
dilating all peripheral vasculature.
What was?
It's dilating the whole peripheral vascular system.
It dilates everything potentially. Yes, right. Okay. So the reason that I'm going to be talking about why I bring this up is there's different things of thoughts, not in this class, but things that you guys might read or might see. So there's some periods of talking about using nitro with AAA, depending on what kind it is, especially if it's a tear or certain aspects. Well, why is the thought process on there? Okay. So if the artery is like this, it's got a small tear on the spot, you got a lot of blood coming up, but it's still going to that tear, especially if they're smaller. There's some person's thought, it's not my thought, but I'm just telling you that's why this is up here to say cautiously to consider that. Some people say if you dilate that artery, you actually open it up more so you got more blood that can go past the area dissection and it's not going out. It's going path of least resistance, right? Everything goes path of least resistance. So they're saying if you inflate it enough, you get most of the blood will go past or going down, will go past and not out that area. I don't know that I agree with that, but there are areas, and so if you guys read outside articles, there's talk of using nitro to dilate that area, to open up the area. So if you're decreasing blood pressure anyway, because now you open it, that's saying more within the center of the artery and it's going path of least resistance and it's not going through the outside walls. Something to consider. I have no science on that. I have no basis on that. It's not in my protocols to give nitro on a AAA, so I'm not going to do it. That's specifically why this is up here to think about it, is there is talk of people talking about different things. And if you can explain to me the science behind something, I'll consider it doing it. That science, it's kind of there, but it's not enough there for me to consider doing it at this point in time. But that's why it's stated that. Same thing, avoiding aspirin regimen. Why do we want to do that? Because we want it, yeah, we want it to clot. We want, if there's any tearing right there, we want clotting to happen. And aspirin basically is trying to prevent that from happening too. And that's the other aspect that they're going with that nitro, is that reflex tachycardia increases that tearing sensation. So the big things we want to do, we want to make sure we're cardiac monitoring. We want to get fast. We want to get large bore IVs going on there. What's this patient going to need? Blood. And we want to do blood through a large bore IV when we get it in. So we want to have that, but we want to get, for National Registry, BP of 90, real life, consider doing a BP of 70. That's a sustained career trauma patients. We think that that's about a normal area that we're going to be looking at. So, but I'm always open to new things out there. I just haven't found that nitro is something that I would be considering for this, and especially without diagnosing. Here's going to be another indication. I'm really a big proponent. I'd love to see bedside ultrasound go out to the field. This would be a great case to find out exactly what's going on. There's a learning curve with going, but once you've done enough ultrasounds, you understand them, you can pick it up real easy. So it might be something in a wave coming down. Something else to see. Questions on aortic aneurysm? No? Okay. Well, that is it today.